Hi, and welcome to today's webcast, Management of COPD in Older Persons. This is part one of two webcasts we'll do on this subject. I'm McKnight's editor, Jim Berkland, and I'll be moderating today's event. Chronic obstructive pulmonary disease, COPD. It's a common disease in older individuals, and it needs vigilant diagnosis and care. It's preventable and treatable, but COPD can be one of the most painful conditions to observe in your residence. That's why we're glad you're here for the first part of a two-webinar series on COPD. Part two, incidentally, will be May 18th. Mark your calendars. You're going to hear about risk factors associated with COPD and learn about available treatment options. And basically, you're going to hear some new info on an old problem. Our speaker, Todd King, is just the guy to fill us in. He's the Senior Director of Clinical Services for Long-Term Care for Omnicare, a CVS Health company. He'll jump in soon, but first I'd like to tell you about some important things for today's presentation. Please get ready for some excellent note-taking opportunities. Slides will not be available for download today, but this presentation will be available for reviewing or viewing for the first time shortly after it ends. That'll be in our archive session. It'll be available on demand by simply going to the registration page by entering this studio. The URL is mcknights.com/April9webinar. You'll see that again at the end of our presentation. If you are having audio problems with this broadcast, please first check the volume control on your machine. You also have a help button you can use if your own troubleshooting doesn't work. Also, we will have time for a Q&A session near the end of Todd's presentation. If you have any questions, please feel free to tap them out and submit them directly to us. You can start now, as a matter of fact. Those we don't get to in real time, we'll try to get an answer to you afterwards. Now, about CEs. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. That's NAB to us. It's been approved for 1 clock hour. However, you need to stay tuned to this event for its entirety during its original broadcast in order to receive a certificate. We'd also like to note this program is made possible by support from Omnicare. Please visit your friends there at omnicare.com. About today's presenter, Todd King serves as Director of Clinical Services for Omnicare. He manages consultant pharmacists and clinical managers, implementing clinical programs and managing facility formulary, while providing education for staff and customers across a wide swath of America. Well, Todd, I know some people may be wondering, why pick COP to focus on now? I think it's a very timely topic. As we know, there's some new guidance that's coming out. And Todd, I'm not sure if we've got a great connection or not, but we'll have you start in with your slide deck as soon as we can get you connected in. I do want to remind everyone that we'll be taking questions throughout this broadcast. We'll answer them at the end. Type them in by the button on the Q&A. This is fresh material, so we think that we're going to get quite a bit ground covered here for you for the first time. Todd, would you say COPD is a rising problem, or how would you characterize that within this sphere? I think we may be having a little bit of technical difficulty on that end. I'm not sure, but we'll be bringing him in momentarily. We will have a two-parter on this. This is going to set up some of the issues with COPD, with recognizing how to handle things on the front end. And then our second webinar, which, will, like as I said, will be May 18th, we'll be taking care of some of it further down the line.
Hey, Jim. Good afternoon. Yes. How are you doing?
Great. Well, Todd, I was asking, I was saying, the COPD is kind of an I don't want to say it's an emerging issue. It's been out there for a while. But why now would we want to focus on it like this?
Well, we've got a couple things to talk about today. We have some new guidelines that have been updated this year, and it's an exciting time in the management of this condition because as we move through the process of managing patients with COPD, it is a chronic condition, and as the condition changes and progresses, we have to make sure that we're adjusting therapies as accordingly and making sure that we're processing and utilizing medications and therapies as appropriately as possible.
All right, well, that seems to set the stage really well. So if you're ready, why don't you take it away?
Thanks again, and good morning and good afternoon, everybody, wherever you're listening from, and I appreciate everybody jumping on the webinar today. There's a lot of great stuff for us to talk about, and some things that we're going to discuss will be new. We'll talk about some medications that are out there as far as managing COPD. We're going to talk about risk factors and define COPD. One of the key factors is utilization of non-pharmacological treatments. As a pharmacist, you know, lots of times I do talk about drugs, and we'll talk about drugs today, but there's a lot of non-pharmacological things that we can look at for treatment options in COPD. And then we'll talk about medications and talk about treatments of COPD, give an update on the GOLD therapy guidelines, which I think are an important update around the utilizations of medications and managing this condition as it progresses. So let's start out with the definition. And when you look at this definition, it is pretty complicated as you go through it, but COPD, or chronic obstructive pulmonary disease, is a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. So when you that's a pretty broad and very long definition, but basically this condition is one that is a condition of damage, and it is an area where the lungs are damaged to the point where airflow is restricted. This condition is managed by the GOLD guidelines, and it's one of the most highly respected standards of care for the management of COPD. And GOLD stands for the Global Initiative for Chronic Obstructive Pulmonary Disease. And GOLD actually did redefine some of their specific areas earlier this year, and we're going to talk about those as we go through today and give you some of the new information. But before we do that, let's go back and kind of look at some of the specific opportunities and areas where COPD, some risk factors, and some opportunities for us as clinicians to help identify, manage, and associate risk. So this slide kind of looks at COPD risk factors, and there are several known risk factors. And when you look at the first section here, particulate exposure, and the key risk factor for COPD is smoking. And tobacco smoke is the most common particulate exposure that does cause this chronic condition. There also can be exposures to occupational dust, outdoor air pollution, indoor air pollution. Increasing age is a risk factor for this condition. Also, when looking at a history on a resident, it's important to see if you can find out if there were recurrent chronic respiratory infections, such as in childhood or things like tuberculosis, et cetera. That is a risk factor also for this condition. And then finally, there is a genetic link that we know that alpha-1 antitrypsin deficiency does actually predispose someone for this condition. Some possible risk factors, lots of times on a slide coming up, we'll talk about asthma. We're not going to spend a lot of time on asthma today, but there is some literature out there that does lead us to think that asthma can be a risk factor for COPD. And there are some differences naturally between asthma and COPD, and we'll talk about those in a few minutes. Gender, females may be more susceptible. Another thing is weight loss and malnutrition. We'll talk for a few minutes today about maintaining nutrition and maintaining a healthy intake of food and how important it is in the management of this chronic condition. This slide addresses the differences between COPD and asthma. And as we go through this, I think it's important for us to kind of keep in mind when you look at the history of our residents, they're often very complicated. The next slide will look at a condition where asthma and COPD kind of overlap. But I think one of the things to keep in mind is there are definite differences between these two conditions. With COPD, we usually see an onset at midlife, greater than after age 35. Symptoms are usually slow and progressive. There's a persistent cough. It can be productive and also be with chronic bronchitis. A long history of tobacco use. That's, as we've mentioned, I'll mention this several times throughout the call today, but I think it's important to remember that tobacco use is definitely a challenge with this disease. Shortness of breath during exercise. When we talk about managing the symptomology of COPD, shortness of breath is actually one of the management tools that we'll look at. We'll look at shortness of breath and also managing exacerbations of COPD that could actually have someone wind up in the hospital. With COPD, the airflow limitation is largely irreversible. So the damage that happens from cigarette smoking, albeit stopping at any age is very good, a lot of the damage is already done. So that is a thing to kind of keep in mind, that the airflow limitations with these conditions are largely irreversible. With asthma generally is an onset at any age, but it's usually during childhood. I have a child, a 9-year-old, who's very athletic, that he has exercise-induced asthma. And you can tell when those stress factors get to him and he has shortness of breath. But asthma also, the symptoms vary from day to day. Symptoms are usually worse at night or first thing in the morning. They're intermittent and potentially a non-productive cough. Lots of times these folks will have allergic rhinitis signs and symptoms. Also, eczema can be present. Lots of them have dyspnea during exercise, which is common with both asthma and COPD. So shortness of breath is something sometimes that can be mixed in together. And then a family history. The other thing that's important to remember about asthma, unlike COPD, the airflow limitation is largely reversible with asthma. So before we continue down with COPD, I wanted to take this opportunity to just talk about a syndrome. This is the only side we're going to talk about asthma COPD overlap syndrome, or ACOS, because it happens a lot in our geriatric population, where people, when we look at past medical histories, we may see asthma and COPD as a diagnosis in a patient's record. It's important to remember that this is a condition that exists, but also we've got to make sure that we look at that history and look specifically at the opportunities to make sure we have an appropriate diagnosis. So when you look at this slide, it's important to remember that this condition exists, but also that it is managed a little bit differently than COPD. So when you look at the GOLD guidelines, you can actually go to the GOLD guidelines and look at ACOS and its management. And that just is a pretty easy website to go out there and search. It's goldcopd.org. So this is a condition that is out there, and I wanted to just address it quickly in a slide, because I know a lot of you do see asthma and COPD together in diagnoses and patient histories. So let's talk about some of the systemic features of COPD. And, one of the things that is interesting and a challenge clinically about this condition is that there are common comorbidities when having COPD that predisposes individuals to other conditions. And I've listed some of those on this slide. Skeletal muscle wasting and disuse atrophy. Basically, as these folks continue to go through the process where they can't catch their breath or they are short of breath, they tend to stop being active. And that's one of the things that we'll talk about as we go through these slides. Cachexia, increased risk of cardiovascular disease, anemia, polycythemia, which is an increase in the hematocrit, osteoporosis, and then probably one that is definitely something that we have to keep an eye on from a clinical standpoint, that is the depression and anxiety that develops with COPD. For those of you who have never been short of breath or couldn't catch your breath, it is a very anxious situation. I know when I see it happen to my son, it's very difficult. It's very difficult to watch. So those types of symptoms should be managed appropriately with appropriate medications or non-pharmacological therapy. So this slide covers some key indicators for considering a COPD diagnosis. And I put this slide's in here because of a couple reasons. One, when you look at the GOLD guidelines, they do recommend that spirometry be used to make the diagnosis of COPD. And a spirometer is a device where, and many of you have seen this, it's a device where you breathe into and you get an actual capacity or ability to assess the lung function. Unfortunately, in our patients, lots of times they are, as everybody on the call knows, they're very difficult and challenging to be compliant with these apparatuses. for a variety of reasons. There's first of all, there's a physiological loss of lung volume with age, which lots of times doesn't allow us to get an accurate reading. But also our folks are often people with COPD are often very frail. They might not have the dexterity. They might also have cognitive impairment, or the unwillingness to do it because the device is a little bit intimidating, I guess. So what this slide does look at is some of the key indicators for considering a diagnosis of COPD that we need to keep in mind when we don't have some of the tools that we need to get that official diagnosis according to the guidelines. So shortness of breath, it is progressive, it's persistent, it's worse with exercise. The chronic cough that we talked about earlier, it may be intermittent, it could be unproductive. Chronic sputum production, any pattern of that may indicate COPD. History of risk factor exposure, naturally we've talked about tobacco use throughout this conversation. And then also family history. We did make the connection earlier about the genetic link to COPD, so it's important to keep that one in mind also. But these factors could actually give you an appropriate pathway to consider a COPD diagnosis without actually having the tools that the GOLD guidelines recommend. Now, one of the things that I think is important for us to consider is looking at the patient groups based on combined assessments that the GOLD guidelines use. This slide actually outlines those, and you can see that patients are grouped according to letters of the alphabet. It's A, B, C, or D. And what GOLD does is it takes the specific exacerbation and hospital risk and then matches it with symptoms and gives the resident or patient a code or a patient group. And what we do with the guidelines is then take that patient group and match drug therapy to it. And that's after we've done the non-pharmacological things that we're going to talk about here in a few minutes. But if you look at this, a resident or patient who has low risk of exacerbations, that's 0 to 1 exacerbation per year, but has more severe symptoms, significantly impaired health status due to COPD, that person would be in group B. And you can go through, and we're not going to go through all of these, but you can see how GOLD has attempted to take patient groups based on exacerbations, hospitalizations, and symptomology and categorize them to give us an assessment to where we can look at grouping patients according to what initial treatment options should be or what therapeutic options should be as they progress through their condition. So let's take the next step and look at our management of COPD. So when we talk about management of COPD, I'm going to kind of challenge you to think about the way that we manage our geriatric population, because I've done several of these webinars in the past, and we talk about antipsychotic medications and psychotropic drugs. We're always trying to reevaluate those and look at whether or not we can take them away, or if it's appropriate now to remove the drug from the resident of the patient. I saw an article in McKnight's the other day where, we're now groups are thinking out there, we've done good with the antipsychotics. Maybe we should look at antidepressants and see if those are being overused. One of the things with COPD is you've got to keep it in your mind that as this condition progresses, lots of times de-escalation of medications or removing medications could actually put the patient at risk for exacerbation or hospitalization. So we need to keep these three treatment concepts in mind. COPD is progressive and cannot be cured. We should take actions to prevent further exacerbations of COPD. And as the further deterioration usually requires progressive introduction of additional treatment, and reduction of therapy is rarely possible even after symptoms are controlled. So one of the things that I think is important for us to kind of keep in mind as we talk about this, there's actually some good literature out there that shows that de-escalation of inhaled corticosteroids may be appropriate, but the reality is once somebody's stabilized, we really have to look at it from a clinical standpoint, from a risk-benefit standpoint, to look at whether or not those medications should be adjusted up or down. So you kind of challenge yourself when you talk about COPD to to think about it in that process. And I think as you go through these slides, you'll kind of understand the way this condition progresses. You'll see the progressions of medications also. Next slide talks about treatment goals for long-term care residents with COPD. We put the bullet on here where the arrow is targeted, that the only therapy that can slow the decline in lung function is achieving successful smoking cessation. So that's an important aspect. There are not as many folks in nursing homes any longer that still smoke, but in assisted living facilities, independent living, in the community sector, there's definitely a lot of that still happens out there. So I think one of the things that it is definitely an opportunity for us as healthcare providers to work with patients on smoking cessation. Other treatment goals are to slow the progression of lung disease, provide symptomatic relief, improve quality of life, prevent and treat exacerbations, prevent infections, relieve anxiety and depression, we've already talked about that, and then naturally reducing mortality if possible. This slide actually goes over some non-pharmacological considerations, and I know I've beat it like a dead horse, but smoking cessation is the number one non-pharmacological consideration. We've also talked about physical activity and exercise training, and I think this is an area that we really need to kind of focus on. And while COPD can greatly impact the resident's ability to actively exercise, lack of physical activity results in further deconditioning, worsening of symptoms, and reduced quality of life. So we really need to encourage these folks to stay active, especially if they can do upper body exercises like limb and arm exercises. And that way, that'll help them with inspiratory muscle training to where they can continue to actively breathe successfully. Naturally, education is important, education around smoking and education around inhaler use. We'll talk about that quite a bit here in a few minutes. I'm not going to go over the proper techniques for the use of inhalers because there are so many different opportunities for that and so many different drugs on the market now that there's a lot of reasons why that part really needs to be focused on the opportunity to provide education specifically to that drug. And then lastly, nutritional counseling. And everybody's kind of looking at this going, nutritional counseling, what is Todd talking about? I mean, we're talking about a lung condition. Let's kind of look into that and dive into it on the next page. I think one of the things that is really important for a non-pharmacological management of COPD is good nutrition. Everyone needs to maintain a healthy body weight and have necessary energy to exercise and perform day-to-day activities. It's been shown that about a quarter of those people with COPD in the community setting are undernourished. And there's a lot of reasons for that. If you think about it, if it's tough to breathe and you're always tired and you're always trying to catch your breath, food is probably one of the things that you don't have a lot of time for or a lot of desire for. So these are some tips that I think are important for us with our COPD patients to make sure that we keep in mind. Consume more frequent small meals, eat a larger meal in the morning, especially if you get tired later in the day. Rest before mealtimes. That sounds kind of trivial, but you need to rest to make sure you have the energy to eat. Drink fluids after meals, not during meals. Fluids tend to make you feel full, and you don't want to eat. Avoid foods that may cause bloating or gas. That really does affect, how much you can eat and whether or not you want to eat. If you're too tired to finish a meal, consume high-calorie or dense foods or supplements. Supplements lots of times are pretty important for these folks who have COPD. So I think the nutritional advice is really important. So making sure in your facility that the dietary folks are involved with the education around how we can manage this condition and help these folks maintain their nutritional status. So 25 minutes in and we get to talk about medications. I think it's important, as most of my webinars that I do, we talk a lot about the disease and a lot about non-pharmacological activities. As we move into the treatment process for this disease, we're going to look at a lot of different drugs and a lot of different opportunities. But these drugs do have places in therapy. And the GOLD guidelines on this slide have actually done a really good job, I think, at kind of giving us an opportunity to understand where the drugs fit. And don't worry about these abbreviations. We'll go through those as we go through the slide deck. But if you look, the GOLD guidelines here have given you a group A, B, C, and D, and given you the actual drugs that fit into that category. So as group A, remember when we go back to the slide, those were folks who had low risk for exacerbations and mild symptomology. Those groups get a bronchodilator, a short-acting beta agonist, a short-acting muscarinic agonist, etc. So as you go through, you can see the therapies that will be added to this. When we go to the next couple slides, we'll actually look at how the GOLD guidelines actually give us a treatment modality and how to advance medications when symptoms persist or worsen. So this slide actually takes shortness of breath. So let's go through the top. This is a summary of follow-up pharmacological management of COPD when shortness of breath is the concern. So as you can see from this slide, you'll look from the left-hand side to the middle and then to the right. As the arrow goes up, as severity goes up, one of the changes in the 2019 GOLD guidelines is how to address inadequate response to therapy. So as this goes up, you can see as at the bottom here, we've got a long-acting anticholinergic and a long-acting beta agonist. And as the severity increases, you may actually add those two drugs together to help manage the condition. But on the other side, we really need to make sure that we're looking at external causes of these symptoms, like an infection or smoking, or make sure that the person knows how to use the inhalers appropriately and how to manage the inhalers to make sure that they're using them according to what is the most appropriate manner. So this is a nice slide that actually where the GOLD guidelines have taken dyspnea and shortness of breath and looked at them as the concern. The next slide does the same thing with COP exacerbations. And this is a really complicated looking slide. So I think it's one, as you go through it, it's to think of it the same way. As the severity of symptoms increase, you're looking at adding medications that are going to be more appropriate for that specific condition. And this is one of the areas where there has been some new things added. When you look here, when you see ICSs, those are inhaled corticosteroids. One of the things that's new to the GOLD guidelines is they have actually specifically put eosinophil counts into recommendations on when inhaled corticosteroids should be used. So if you can see at the top up here, as symptoms increase with exacerbations, you may see a long-acting anticholinergic plus a long-acting beta agonist plus an inhaled corticosteroid if the resident has eosinophils of greater than 100. The guideline does specifically say that if eosinophils are less than 100, then inhaled corticosteroids are not recommended. You'll also see in this section you'll see a recommendation for azithromycin, which is an antibiotic, to be put in there for folks who are former smokers that may be able to help prevent infections as they go forward. So this is a pretty aggressive slide that looks at how exacerbations are managed from a concern standpoint. And I think GOLD has actually really given us a nice stepwise approach to look at severity of symptoms and how we should progress medications. So the next few slides that we'll go through talk specifically about medication selection. So when you look at considerations for product selection, I think one of the things that we'll talk about as we go through here is we match the product to the severity of the disease and the individual's ability to adhere to therapy. We should try to use inhalers with similar administration mechanics. Remember, we talked about, and those of you who are nurses who are actually work with direct care need to be aware that, you're aware of how these medications, all the different inhalers and how they work and that type of thing. So making sure that the resident has included in their assessment their dexterity, their ability, and their preferences on the inhalers, how they should utilize them, and how they should manage them accordingly, and if they need help with those inhalers. Consider the impact that multiple inhalers may have on compliance and acceptance, i.e. cost. Cost is something really to take into consideration, with these products, because these inhaler devices are very sophisticated. They're very they're very delicate, and there really needs to kind of keep in mind how that'll affect things. And, as we move forward, we were talking about it earlier today, as we move forward with the changes in our reimbursement process with PDPM, these medications and the management of COPD is going to be critical, especially when the resident comes from the hospital into a long-term care facility, because their medications may have been changed a little bit while they were in the facility or in the hospital, and now when they come to the nursing facility, we may need to tweak those medications further. So management of COPD and PDPM is going to be a real challenge because of the cost of the medications. And when you're dealing with non-therapy ancillaries, it's important to remember that that's definitely going to be something we need to keep our eye on. So let's kind of go through. The next few slides will be talking specifically about medications. I've included generic and some brand names here for you just so you'll know what they are, and actually included all the abbreviations there too, so you can have those as we go through this. But let's talk quickly about how these slides are set up. Each one of these will have names of the drugs at the top, and then the 3 boxes below it will have when they should be used and how they work, and then adverse events. So the inhaled short-acting beta agonist, you can see the names of the drugs there. You're probably most familiar with albuterol and levobuterol. And these products are available as inhalers, metered-dose inhalers, and nebulizers. These drugs tend to be used for rescue inhalers. They can be used as needed. They may be used early in COPD with infrequent symptoms. And these drugs relax the smooth muscle in the lungs and provide fast symptomatic relief and actually provide nice bronchodilation. However, they do have some side effects, and you'll see those here: tachycardia, tremor, insomnia, headache, and hypokalemia. These drugs do cause a little bit of a diuresis, so it's important to remember to look out for hypokalemia, but most patients do complain of the tachycardia and the tremor. Some people say that there is less severe side effects with lead albuterol. That's Zopanex by the name that you know it, and some people do experience that, so the symptoms may be a little bit less, or the adverse events may be a little bit less, specifically the tremor and the tachycardia. The long-acting beta agonists, these are products that are very similar to the short-acting. They are long-acting, so they're more effective than the short-acting at maintaining relief. So think about this as a long-acting blood pressure medication. They control the blood pressure throughout the day or time period, whereas the short-acting medication does not do that. They're more convenient. They can be used once or twice daily. They have a slower onset of action, and actually their side effects are very similar to the short-acting beta agonist. Inhaled short-acting anticholinergics. These are drugs, the ipratropium is the primary drug here, and there we go. Appropriate as these can be used on an as-needed basis. They may be used early in COPD with infrequent symptoms. These drugs work by blocking the effects of acetylcholine on the pulmonary muscarinic receptors, which causes bronchodilation. The effects of these medications last longer than the short-acting beta agonist, but has a slower onset. So if you're using this as a shorter-acting product, then you may actually see this to be a product that you would need to have. It has a shorter onset. Adverse events, since these drugs are anticholinergic, that's how they work. That they have the similar anticholinergic side effects that you would see with other oral medication: dry mouth, bitter metallic taste, urinary retention, cardiovascular events, acute glaucoma with nebulized products, etc. The long-acting anticholinergics, you probably know these drugs as tiotropium is most commonly used. These drugs may be used as an alternative or an add-on to long-acting beta agonists. Remember, we saw when we went through the GOLD guidelines and the stepwise approach, we did see specifically where there were opportunities to add these two drugs together. These drugs are more convenient than the short-acting inhaled long-acting anticholinergics. They're not for rescue and use. they're often used once or twice daily. So one of the things to keep in mind as you talk about short-acting versus long-acting is really looking at whether or not the resident or the patient can be compliant with the medication based on the frequency of the times a day that the drug has to be given. And then the adverse events of the inhaled long-acting anticholinergic are very similar to the short-acting. So now as we talked, and you can imagine as we go through these, everybody knows that we talked about individual products. Well, you know, the drug companies have come out and figured out that we can actually combine these products together and create products where you've got two drugs in combination. You can give them less inhaled product, less frequently, et cetera. So we're going to talk about combinations as we go through these next few slides. The combination inhaled short-acting beta agonist and short-acting anticholinergics. You can see albuterol and ipratropium as these two combination products. These drugs, this combination may be appropriate for all residents with COPD if a single agent provides insufficient control. These drugs relax the airway and the smooth muscle, and the adverse events are the same as the other medications. Even though you're combining these products, you're really not reducing the potential for adverse events. The combined long-acting beta agonist and long-acting anticholinergics, these drugs are medications that are combined together to be more convenient than separate long-acting beta agonists and long-acting antimuscarinics. The combination may produce a greater degree of bronchodilation in this category. So I think it's one of those to kind of keep in mind. These are generally used, these long-acting beta agonists, long-acting anticholinergics are used in the initial management of gold group D, or whenever a single long-acting bronchodilator fails to provide adequate relief. It's believed that the combination of two long-acting bronchodilators may produce a degree of bronchodilation that is greater than when they're given individually. This is a combination, too, that you may see associated equal or fewer side effects than the individual products. Inhaled corticosteroids. Remember we talked earlier about inhaled corticosteroids and how, where their place in therapy is. The inhaled corticosteroids exert their therapeutic effect in COPD by reducing inflammation in the respiratory tract, but to a lesser extent than in asthma. Not everyone in COPD will benefit from these drugs. These drugs generally are added to long-acting bronchodilators for the initial management of select persons in gold group D, and is add-on therapy for individuals with selected exacerbations. As I mentioned, they reduce inflammation in the respiratory tract and reduce frequencies of exacerbation. Challenges with these medications are the side effects. Since they are a steroid and you're using it in the mouth needs to be rinsed after usage to prevent a thrush infection. You can have a hoarse voice, skin bruising, osteoporosis. There is an increased risk for pneumonia also. Other combination products, this is a combination of the inhaled long-acting beta agonist and inhaled corticosteroids. This product is probably one of the ones that's most commonly used. This is a treatment option for Group D and poorly controlled Group C patients is the combination of these two products. They may help reduce the risk of exacerbations. It is important that corticosteroids should never be used as monotherapy in COPD. As we talked about in the previous slide, those inhaled corticosteroids should always be an add-on. They're more effective than individual components alone. And some of the adverse events are similar to individual agents, specifically the increased risk of pneumonia. So as we continue to go through these slides, one of the things that you can see is that the manufacturers have continued to add products to the regimens. The product listed here is a triple component. It is a combination of an inhaled long-acting anticholinergic long-acting beta agonist, and an inhaled corticosteroid. The thought process here is that in once daily administration for maintenance and prevention of exacerbations plus less adherence problems. And of course, as you look at the GOLD guidelines, this combination product is appropriate when a long-acting beta agonist and an inhaled corticosteroid results in only partial control, or when exacerbations occur in select individuals with exacerbations while on both, and they have an eosinophil count of greater than 100. Adverse events are similar. This is a product naturally because if it has the inhaled corticosteroid, the mouth needs to be rinsed after use. A couple other medications here, phosphodiesterase 4 inhibitor, Romfulast is Daralisp, and this is a product that is kind of interesting. It has no direct bronchodilation effects, but does reduce respiratory tract inflammation through a unique mechanism, and thus has been shown to reduce exacerbations and hospitalizations. You know, it should be used only in combination with long-acting inhaled bronchodilators. The adverse event profile, as you can see here, gastrointestinal side effects, sleep disturbances, weight loss, and psychiatric events. And I think as you look at those specific adverse events, that's one of the reasons why this product, I think, is really going to have to be carefully assessed before it's used in our geriatric population, but specifically because if you think about all of those side effects are very common things that can happen to our geriatric population. So this is a drug that we see used fairly uncommonly, but it does have a unique mechanism of action, and it is an oral medication, so it does have that benefit in case that the resident has challenges with using inhalers, but it does have to be used in combination with a long-acting inhaled bronchodilators. So not an absolute solution, because it's generally not used by itself. So just to kind of a few more slides here, the GOLD guidelines did look at specifically other medications, and I think it's important to really look at these and make sure that we kind of address them. The methylxanthines, those of us that have been around for a while remember theophylline, and theophylline was a drug that really was used quite extensively many, many years ago, and we were able to move away from theophylline when the inhaled products started to come on the market. And the thought process naturally was getting the drug directly into the lungs by using an inhaled product would help and avoid some of the side effects. The problems with theophylline are a lot of peripheral side effects and a lot of challenges with managing those. It's also a narrow therapeutic window index drug, so it has a really narrow opportunity of it being effective. And lots of times we saw that concentrations greater than 11 should have a prompt evaluation in our older population because that can lead to side effects. One that I didn't mention earlier that some of you probably still see out there some is the albuterol products that are still available as tablets and liquids. You probably still see those out there some. They're generally not recommended in COPD because of their specific long-term peripheral side effects. The tachycardia, the gastrointestinal side effects with those products are significant and really shouldn't be used in COPD where we have inhaled products. You'll see them used in kids some because they can't use the inhalers, but generally in our population they really shouldn't be used. Long-term administration of oxygen greater than 15 hours a day has been shown to increase survival for those with severe resting hypoxemia. So that's the GOLD guidelines do address those also. Occasionally you'll see mucolytics be used like guaifenesin or acetylcysteine. These products really are, guaifenesin is really not recommended in those with stable COPD. Maybe can be used during an infection or something like that. Inhaled acetylcysteine may reduce exacerbations and modestly improve health status. But once again, it does thin secretion so they can be easily coughed out. However, an individual needs to have the ability to adequately clear their own secretions before they should be considered to use those products. We would be remiss if we didn't talk here at the end about vaccines. It is important in people who have COPD to make sure that they are vaccinated regularly. Influenza vaccine should be given. It can naturally help reduce the flu, and also is good in folks who have COPD to make sure that they're not latent with another infection while they're trying to develop and make sure that they're trying to breathe. Pneumococcal vaccine should also be administered to these folks. And then lastly, the pertussis. I mean, this is one that we kind of forget about over time, but the whooping cough pertussis is actually associated with COPD exacerbation. So it's generally recommended that one of the DTaps should be replaced every 10 years with a pertussis vaccine. So to tie everything up here, I think one of the things that's important with the management of COPD is it is an interdisciplinary process. And in the long-term care facility, in an assisted living or an independent living facility, early intervention and tailoring of maintenance medications are key to preventing exacerbations in hospitalizations. It's very important that the team be involved in the ongoing identification and monitoring of the resident. And I think one of the things to remember is when you look at the symptoms that are on here and that we're showing in this last slide here, shortness of breath is the major impact on the quality of life with residents in COPD and can cause significant anxiety due to their inability to inhale and exhale amounts of oxygen. But when you look at this list here, these other monitoring parameters can help us make sure we can identify when that resident may be moving into an exacerbation. And an exacerbation is, when the resident has severe shortness of breath, may require more medications or short-term use of other inhalers, et cetera. So when you look at the symptomology on here, we talked a lot about shortness of breath today, but I think as we look at it, we need to make sure as healthcare professionals, when we're dealing with this condition, is looking at shortness of breath, but also looking at cough and sputum production, chest pain, tightness in the chest, fatigue, weight loss, anxiety, and depression. So I think these are things that as we look at these as we go forward, it's important for us to really keep in mind that there are a variety of symptomologies that we look at when we're trying to assess someone with COPD. So in closing, I think as you can see from this condition, it is a very multifactorial condition. There's a lot of potential for non-drug interventions and non-pharmacological interventions. When we move to medications, it really is important to make sure that we follow the standards of practice, which are the GOLD guidelines, and look at how we manage this condition based on the symptomology and also the exacerbations, and manage according to what the step therapy looks like from the use of inhalers, et cetera. So I think it's one of those to really make sure that it is a multidisciplinary process. We do have new guidelines out there that can really help us with the condition and also the maintenance. So it's a great opportunity as for folks who manage this condition to really have an impact on those patients who have COPD, because if you've ever worked with them, it is really a challenging condition to be constantly short of breath and constantly worried about whether or not you're going to go into an exacerbation, et cetera. So once again, I'd like to thank everybody for joining today, and I'm going to turn it back over to Jim for some questions, and I hope we do have some out there, and I look forward to interacting with the group.
Well, yes, we do, Todd. Thank you very much. What a wonderful presentation. I mean, just thorough, covering a lot of very, very important materials and treatments, as you indicated on it. And we have some questions. I'm going to give you a chance to catch your breath, and I'm also going to give myself a chance to correct myself from something I said right at the start, because you're all going to want to come to part 2 of this series on COPD. That second part will be May 21st, Tuesday. We weren't expecting you to come in on Saturday, as it were, on that other date I gave, so I don't want to repeat that mistake, but we will be May 21st will be the next webinar in this series for that, and we'll certainly make you aware of that otherwise. So I apologize for that false information early on. But if you're ready, Todd, I do want to jump right in. We've got some great questions. I want to encourage everybody to send in any that you might still have. So Constance asks, how does secondhand smoke affect development and treatment of COPD?
Interesting question. Thanks, Constance. I think, when you look at secondhand smoke, there has been definitely some correlation to secondhand smoke and the ability to contract some of the symptomology and also some of the complications to cigarette smoking. However, I don't know that there's a specific connection between secondhand smoke and the development of COPD. But it's always one of the things to consider is, making sure that where there are opportunities that we help people reduce their smoking or stop completely, it really can help, their overall condition. So if a loved one lives with somebody for 50 years in their home and one's a smoker and one's not, you can see some of that symptomology in the person who didn't smoke. The other question that comes up, and I'll address it because the GOLD guidelines talked about it, is for younger people or people who are living in the community, are the newer products, the vaping products that are out there on the market, are they considered a successful smoking cessation program? And the GOLD guidelines specifically said that we do not have enough data on that right now. So I think that's what you're seeing a little bit more now. So in younger people or people that think that they're, in their 50s or whatever, that this might be an alternative and might help me down the road, there's really not any conclusive information on that at this point. So I would not recommend that as an alternative or a successful smoking cessation program.
That is an excellent addition there, Todd, because isn't that kind of getting pervasive in so many things that we're doing here? Okay, Christine has a good one. Do you recommend a COPD rescue kit for patients in their homes following acute care discharge or preemptively to prevent emergency room utilization and readmission?
When you look at COPD rescue packs, and for those of you who might not be aware, it's actually a pack that has a supply of a corticosteroid and usually an antibiotic that can be in the home setting, and kind of like I think of it almost like as a hypoglycemia kit or something like that. I don't think it's a bad idea at all, as long as it's under the advice of a physician and a prescriber. Because if you think about it, that we talked about inhaled corticosteroids earlier today. We didn't really get into oral steroids very much. And I think, we focused on the GOLD guidelines and the treatment guidelines there. But I think it's important to remember that the place in therapy for those exacerbation products is what we'll cover in the next presentation. But I don't have a problem with rescue packs. I think it is an opportunity where if someone is in the home setting, that it might be a successful utilization after a hospitalization. But the key thing is, as we talked about today, is making sure that when those folks come out of the hospital and go back to the home or come back to the long-term care facility or assisted living facility, that we do an assessment of their ability to use the products that they're on. So, if they come with a new inhaler, we're really remiss as healthcare professionals if we don't take the time to review how that inhaler is used appropriately, because most of them have their little idiosyncratic things that have to be done to make sure that they're used appropriately. And we could spend a whole day going through each individual one of those products. But I think as pharmacists and nurses and prescribers and people who are interacting with these patients, there's an opportunity for us to have a major impact on their ability to stay out of the hospital and to stay healthier if we just take the time to make sure that they know how to appropriately use those inhalers, that they know they need to rinse their mouth after their Advair inhaler because it's got a steroid in it. Because if anybody out there has ever seen a bad case of thrush in the mouth, one, it's not pleasant and it's extremely painful. So, that's just a great opportunity for us as healthcare professionals.
Okay, we want to make sure, there are so many good questions, but this is a good segue too, Todd, that about using an inhaler. Nicole asks, are nebulized airway maintenance medications sufficient for the patients with poor dexterity or the inability to follow instructions on proper inhaler technique?
Yeah, that's a great question. We do see that a lot in long-term care facilities. And, as someone progresses and they no longer have the dexterity, the mental ability to utilize inhalers effectively, nebulizer medications are an alternative. And I think that's one area where we didn't spend a lot of time on it today talking about nebulizers, but they do offer, where they are available, an alternative to those medications. So I think, nebulizers are naturally, they do take a little time. There's also, usually need to be monitored by a nurse or someone in the home setting, maybe a home health agency or something to that effect. So they do take a little bit more time management standpoint. But I know the nurses could give us a little bit better insight on that than I can. But they are an alternative, absolutely, for those folks who have lost their ability to use the inhalers.
Okay, I don't know if you have a few thoughts on this, and then we'll go to a final question. But Deborah asked, what about positioning and recommendations when resting? Do you have anything particular on that, or is that more of a nursing question?
Positioning for the use of inhalers or positioning for effective breathing? I guess
I would think the latter, but I don't know for sure.
Yeah, I think if you're utilizing your inhalers, naturally the person should be able to get a deep breath. So making sure that they are positioned when appropriately administering those drugs, I think, is definitely something. When you look at processes to do that and you look at instructions, the resident should be, in my opinion, sitting up, be able to take a deep inhalation and a deep exhale to make sure that the drug is getting to where it needs to be activated, which is in the lungs.
Okay, very good. Now, we're cutting a little bit short on time, so I have to ask you, what would be the one thing, of all the many great things they've learned today, what would be the one thing that listeners really need to take from this presentation today?
Yeah, I think a couple things. When you look at the treatment guidelines, they are very specific to managing symptomology and managing exacerbations. And as the condition progresses, we have to look at those individuals differently. And as the last slide that I think is still up here, looking at all of those symptomology to make sure that we're making adjustments in medications and non-pharmacological interventions that best suit what the clinical presentation is. So if it's shortness of breath, we do this. If the patient's at highest risk for exacerbation, we do this. I think those guidelines are there to help us as clinicians to make sure that we maximize what we're using from a non-pharmacological and a pharmacological standpoint. So I think that's kind of the key. As long as we've got standards of practice out there, we need to follow those and make sure that we are utilizing them to our benefit, and lastly, and most importantly, the patient's benefit, because these folks who have this condition, they suffer from anxiety and depression and all the other symptomology that goes along with the comorbidities that they have with their blood pressure and all that kind of stuff. There's a lot of stuff going on. So anything we can do to help them breathe better helps them holistically, and I think that should be our goal.
Excellent advice. Well, I do want to say we hope that you've all enjoyed today's webcast. This session will be available shortly at mcknights.com/April9 webinar. And we want to give our special thanks, of course, to Todd King for an insightful look at COPD and so many of the clinical care aspects you need to know about it. And we want to thank our session sponsor, Omnicare. Check them out at omnicare.com. And, of course, our listeners, as always, have been a big part with excellent questions. We look forward to seeing you again at future McKnight's webcasts. You can keep up to date on all the offerings by checking the events tab at mcknights.com, including Part 2, where we continue the COPD discussion on May 21. That is May 21. Once again, I want to thank you for tuning in. This is Jim Berkland for McKnight's, wishing you a good week.